Well, thank you for inviting us to be here today. And the two previous presentations talked about education and research. This is the group who's going to take that and put it into practice. So ours is about taking what we know and what we do and taking that passion for that and putting it into practice. And I would like to start by sharing a basic framework that I believe in. I actually have some colleagues who I've volunteered with in the room here. I believe that as a nurse in practice, I was a cardiovascular nurse specialist. I made a difference in my patients and my patients' families' life every single day, every single patient, every encounter. And when I became a cardiovascular service line administrator or an assistant administrator, I made a difference in the life of my community where my institution was located, and more importantly, the team members that worked with me and for me. But when I became a volunteer and worked in public policy and worked in advocacy, I had the opportunity and the responsibility to impact entire populations of people's health at a time. And so our conversation from the practice area is how do we engage that almost 3.9 million of nurses that are out here in the United States today to become advocates and to make a significant difference. And it's not always through what we do at the bedside or what we do at work, 7 to 3. Oops. So one of the first things I want to point out is a strategic initiative of Nurses on Boards. That came out of the last Institute of Medicine. And in our Louisiana Action Coalition, Cynthia Bianami is still, where are we with Nurses on Boards? Nurses on Boards. And so we have an active group that does that. I am bringing you today stories from the field, how nurses in their volunteer work become advocates for social change and address those social determinants of health. And the first thing that we can do is make sure that we have nurses on boards. The first example will be the Faith Fund, which is a micro-lending alternative to get people out of payday lending hell. As the chairman of the board for Catholic Charities, in 2015, we had a legislative push to put a cap on payday lending interest rates. They can be as high as 3,000%, if you can believe that. It's just horrible what our people in the community and our team members get sucked into. Well, that didn't pass. We failed miserably. You have a bunch of volunteers trying to work against a huge lobby. And so what we heard from the legislators was there are no other alternatives. These poor people just need payday lenders. So we sat down to figure out, is there another way to go about doing this? And through three grants from the Campaign for Human Development, Catholic Charities, our institution, and Metromorphosis, which is an urban planning, put together a not-for-profit, a 501c3, got a community development funding organization, a CDFI, our credit union to come into this, and we launched the Faith Fund in October of last year. It is a micro-lending alternative. In the first week, 183 of our team members, these are gainfully employed people in our organization, and I have 8,000 people on our team. 183 of them applied for a loan. $194,000 was the total amount of loans granted to them to get them out of this payday lending hell. But what it saved them is $225,000 additional. That's how much interest, loans, and fees they were going to pay. It's a 2-for-1 return on investment. These types of initiatives can and will happen in your organizations if you allow your team to really get creative and go forth. Getting involved, standing up, speaking out, making a difference. This is the basis of who we are as nurses. Let's give our nurses a way to express that through volunteerism. The next one is through the eyes of a public-private partnership with a state. As a nurse, at that time I was working with the Louisiana Hospital Association, and I was the vice president of policy and research. One of the American College of Surgeons leads for their advocacy committee came and said, we need to build a statewide trauma system. And we had attempted to do that as a state twice before with our colleagues at EMS, and we failed. So what we did was we said, okay, let's learn from the past. And we got the governor to identify us as a workforce. We did a year study. We brought the information together. We went around the state. We listened in every corner of the state, stories from the field about how terrible it was and why people were dying because we did not have a statewide trauma system. And what I share with you is over time, you can see where we had 2 trauma systems. Then we started our work and we got to 4 and 5 of our regions. We have 9 regions across our state. We still have 3 that are underserved, but we're on a process to do that. I will share with you that there is a position on this LEARN board from the State Board of Nursing. The chairman of our LEARN board is a nurse, and she's also an administrator at a rural hospital. And I'm just the dinosaur that's been there for so long. I'm the past chairman and on the executive committee. Nurses setting policy. Once we said there was a backbone of trauma, we said, well, what's happening with stroke and heart attacks? And so because of my volunteer work with the Heart Association, we pulled them in. And so in 2010, we amended the legislation to include time-sensitive illnesses and built systems of care for stroke and STEMI. Once again, nurses in policy positions serving on boards of directors. It was not always easy. We had lots of times that we had to deal with budget cuts. We originally started this work at the state with a budget of about $6.3 million. We're now down to $1.7. But we got creative and figured out how to use a low-income needy collaborative grant to be able to match state dollars and get additional dollars to the feds there. Once again, looking at how we equitably distribute care across our rural state. Sometimes taking a leap of faith is what we need to do. The last one that I want to speak with you about is about Healthy BR. This is the Mayor's Healthy City in Baton Rouge. I was sharing with one of our public health colleagues here today that we don't have a public health department in our city. We're about 475,000 in our parish. I'm in Louisiana. Yeah, we do Napoleonic law. We don't have counties. We do have a consolidated form of government, which makes it very easy to have one parish structure with 5 cities in it. Go figure. So when our mayor back in 2004 signed on to the National League of Cities to become a healthier city, it got to 2007 and he hadn't done anything. So he reached out to then State Senator Bill Cassidy, who's a physician, and he reached out to me as a nurse volunteer in the community and said, go tell me what we need to do to be healthier. We don't have a public health department. We spent about a year listening. We went to 40 plus different community organizations across the community and asked them, tell me what you do, how do you go about doing it, what do you want to see you doing in the future? And what we did is we came together and told the mayor that we had benevolent citizens. We're a very community engaged community. What we don't have is a coordinated effort around that. We have duplication and we have gaps. And so the vision was to create this Mayor's Healthy City initiative. It is now a 501c3, not-for-profit. The mayor's office staffs this work with their outreach coordinator. And this is the board of directors. You heard earlier about you must engage and include community representatives. You know, every one of our hospitals, there are 5 competing hospitals in our community. Every one of those hospital CEOs has a seat on this board. And you can see where the other research institutions and higher education learnings, as well as public sectors, are present as well. This public-private relationship is how we choose to address the health of our community. What I will tell you that is different about who we are and how we work is that in 2010, with the Affordable Care Act, we saw this as a really good opportunity to have all the hospitals work together. And so we created, back in 2012, the first collaborative community health needs assessment. In 2015, we had pushed the limits of what the IRS had put out as far as regulations, because they really hadn't put them out yet. And we created a joint community health needs assessment. All 5 hospitals weigh in at the same community health need assessment. That means all 5 boards agreed on the same population. What was different about our community is we have one community health implementation plan. Face up on the website for the entire community, and each of our institutions has to report into that. And it's not, while it is a tax document required by hospitals, every one of our partners weighs in on that and puts the information they have available to them. Now, fast forward to 2018, where we still have a joint community health needs assessment and a joint implementation plan. This year, the hospital CEO said, yes, we feel we need to start doing something with social determinants. You know, we do hypertension, or we do this lipid clinic, or we do these things to take care of these types of issues. But we don't know what we can do about social determinants. And so we brought to them the idea and the concept of agreeing to do an anchor strategy. And how we did that sounds so simple, but y'all, it can be so complex if you can't put it in language that the CEO can understand. Do you hire people? Oh yeah, we hire people. Do you buy stuff? Yeah, we buy stuff. And do you make investments? Well, yeah, you're gonna make investments. Okay, well, we're not gonna talk about that one. Let's talk about the first two. So when we put it in very, very, very easy to understand approach of an anchor strategy to get further upstream on social determinants, they all signed on and said, yes, we want to do this. And what they did was the board kept their anchor strategy about economic improvement, investing in disinvested communities as their strategy. So each one of the 4 health priorities that we have in our joint community health needs assessment have task forces that work on them, but the social determinants of health and the zip code disparities is held by the board itself. Now, how we go about doing this work is, our science colleagues taught us this a long time ago, is you have to have this social impact. We use a social impact model, and the Mayor's Healthy City is that backbone organization, but we are very much in tune to making sure that we engage and include the community as a whole. This last time, to hear the voice of the community, we put our 10 significant health priorities face up on the library system's computer for a month. And we had almost 600 members from across the community weigh in on how they prioritize what our efforts should be. 27% of those came from our top 7 zip codes, our zip codes that have a community index greater than 4.2. So we heard the voice of our community. Very important that we approach this way. And using this public-private model, as many cities, and we've had some of these conversations, budgets keep getting cut. The private sector has to step forward and work more closely with the public sector if we're going to really accomplish some of these things. So we believe this collective impact model and using a backbone organization to bring everyone together is a very, very solid way to do that. My last comment would be about the 3.9 million nurses. Imagine the future if you could unlock or unharness the passion within every single one of us that went into this profession to be able to be voices for and with those whom we serve. There is no telling what we could accomplish collectively. We just have to always remember the why. Why did we get into this? And how do we continue to give people the opportunity to act on their why? Thank you.